So we're going to start this morning hearing from Mr. Al Gobeille. Al is the chair of the Green Mountain Care Board, and he is tasked with directing the board's charge of curbing healthcare cost growth and reforming the way healthcare is provided to Vermonters. That's a pretty big charge and undertaking. Al is a restaurateur and well-known businessman in Burlington, Vermont. He owns a chain of restaurants and is a hospitality business, employs about 230 people here in Vermont. He is also a Shelburne resident and a member of the Town of Shelburne Select Board, as well as sitting as a board member on the Visiting Nurse Association of Chittenden and Grand Isle counties. Al is a graduate of Norwich University and has served in an officer in the United States Army, just as myself. And just a quick little brief story, when I was testifying the Green Mountain Care Board early on this year, Al was making a couple of references to being in the service, and I went up to him afterwards and said, "Gosh, Al, I was in the service as well. Where were you assigned?" He says, "You never heard of it, John. It's a tiny little town way up in northeast Germany, right in the height of the Cold War." I said, "Try me." "Well, it's called Gelnhausen." And I said, "Well, I was stationed in Gelnhausen for 3 years." So anyway, we have a little bit of common history. Al Gobeille.
Thank you, John, and thank you, Team VITL. Appreciate you having me here today. As John has said, I'm a restaurant owner. Restaurant owners are not known for PowerPoint presentations. I'm going to attempt to make this complicated system here work. I will do my best. If I fail, I'm going to have like 3 people running towards me. So, as John said, I am the chair of the Green Mountain Care Board. I took over from Anya Rader-Wallach August 1st, and I will tell you that the team at the Green Mountain Care Board is phenomenal. We have a great group of people. The board is a highly functioning group of 5 committed people. And I've enjoyed working with them as a part-time member, and I can't think of anything else than it will continue as chair. I believe Alan Ramsey is here. Alan, I'm not sure where you are. I don't want to make you stand up, but to my family doc, I want to give you a little round of applause, some love this morning. Thank you, Alan. I'm excited to be here as we explore how to best use technology to advance the patient experience, improve the collaborative ability of our providers, and build a more efficient delivery system. I hope this morning to communicate my personal views on why these 3 things must be accomplished and why our efforts to translate into better care. I began this little life adventure that I have into health reform with the realization that healthcare simply just costs too much for my employees. We must confront the reality that our system is not sustainable, and we must change. And so, the magic year in my life is 1964. That's the year that I was born, and it's also the year of my favorite muscle car, the Mustang. Healthcare in 1964 was a little over 5% of our GDP, and in 2008 dollars, cost about $500 per person. By the time of the birth of my daughter, healthcare had risen to, roughly 13% of GDP, and it cost about $2,000 per person. By 2008, it had risen to 16% of GDP and about $7,000 per person. It's projected to rise to almost 19% of GDP by 2018 and upwards of $14,000 per person. Cost is not everything. All of you in this room are not consumed by cost. You're most likely consumed by the job you have in front of you of caring for patients or making technology work, or just simply getting through the day that you have in front of you. But it is this large-scale cost that affected my life as a business owner and affects the life of my employees. This is the average Vermont family. I drew this last night. Okay, I'm lying. Let's say they make $60,000 a year. That translates to about $30 an hour. So the question would be, what does health care cost this family? Well, under the Affordable Care Act, in the exchange as an individual, as a family, with subsidy, it'll be about $6 an hour. You think about that, it's about 10% of their gross income. That's a lot. The problem is, without the subsidy, for the Platinum plan on the exchange, which some people could say I chose a rich benefit, but how many people here want not a rich benefit? Anyone? Okay, that's none. So the cost without subsidy is almost $11 an hour. Think about that in relation to that hourly rate. When I bought my first house, people said, mainly the bank, that I couldn't spend more than 28% of my income on my home. That was kind of the level that they held us to. This makes health care more than that in terms of someone's income. That's the personalization of this crisis we have in our country. I can't get past this. We can talk about why we spend this much, what percentage of the population we spend it on, how few of us we actually spend the most on. But when I think about the people that work for me, when I think about all of you, I think about what we have to pay for insurance or what we have to pay for our benefits. And I become deeply concerned. And I'm sure that all of you do as well. But we're not here today to talk about insurance or the cost of health insurance or the cost of health care necessarily. The question is, what does this do? What this does is it creates a phenomenal amount of pressure on all of us to innovate. We feel it in everything that we do. I would argue that there's 400 people here today, not because I'm speaking. God, I hope you're not here for that. But that you're here today because you're feeling the pressure to innovate. I'm feeling the pressure to innovate. I know John is feeling the pressure, and probably the VITL staff, but many of you. And if you're feeling it, this is where it's coming from. The problem is the cost alone provides no answers. You can't simply say, well, we'll just cut the cost. Well, you could. How many people in here just want to cut their salary in half? That can't be the way we do this. We have to do it in a smarter, more enlightened way. So, restaurant guy sees a problem and decides to throw his hat in the ring for the Green Mountain Care Board. Well, first of all, what is the Green Mountain Care Board? The Green Mountain Care Board is a board that lives in a duality. We have a regulatory side and we have an innovative side. We regulate hospitals, specifically hospital budgets, hospital capital planning under a process called Certificate of Need. We regulate insurance pricing through a complicated process called insurance rate review. So we have incredible regulatory powers to affect the system of care that we have in the state, but we also have an innovative side. We've been charged by Act 48 and the legislature to develop pilot projects that test different models of payment and delivery to try to figure out more efficient ways to deliver care to the patient. In everything that we do, we try to think about the patient first and how it affects the patient, not putting cost first or quality first or access first, but putting the patient first. That's where the Green Mountain Care Board comes from, and if I ever don't do that, Dr. Alan Ramsey gets very upset with me. It's easy sometimes to focus simply on cost, but everyone in this room knows that at some point that's just not enough, and that's not what the patients or the citizens of Vermont want. So where are we headed as a state and federal government? What are we trying to do about it? How many people in this room have heard of the SIM grant? How many people in this room think they're getting money from the SIM grant? Everyone who raised their hand gets some. Whoever didn't, doesn't.
Wait a minute.
Did you raise your hand, John?
Yes.
So the Green Mountain Care Board and the Department of Vermont Health Access co-authored a grant application to the federal government to try to get $60 million in a state innovation grant that allows us to test different models. We did not receive $60 million, we only received $45 million. The interesting thing is, to a small restaurant owner, $45 million sounds like the lottery. $45 million as the numerator to a $5 billion healthcare annual spend in Vermont is actually very little money. I would argue that the money is not what is profound in the SIM grant, but it is the will of the federal government and the state government and the provider community to come together to test different models of payment and delivery. Don't get me wrong, the money will help a little. It is, by the way, spread across 3 years. The grant is 3.5 years, but most of the money is spread over 3. So the question would be, what is the SIM grant? Well, the SIM grant will test 3 distinct payment models. First, shared savings, accountable care organizations across multiple payers. That's a mouthful at 8:45 in the morning, but what does it really mean? What it means is that we will create as a state the opportunity for what I call the coalition of the willing to participate in payment models that sort of mirror the Medicare ACOs that many providers have already signed up for. We have 3 ACOs in the state right now, 2 that are active, 1 that has an application in with Medicare, that will participate in a Medicare ACO. It's the goal of the state to produce a commercial ACO and a Medicaid ACO for January 1st, 2014 to help the state move away from fee-for-service. The most important thing that I want you to take away this morning from my discussion about the SIM grant is not the money and it's not the time, okay, that we have to do it. It's not the fact that it's scary to do so much at such a high pace, which it is for me and it probably is for all of you. The key thing I want you to take away from the SIM grant is that we cannot do it without a robust VITL network. We cannot do it without technology. You cannot have a value-based payment system at that large of a scale without the information to support it. It just simply won't work. So any of you here who work in technology, I believe the pace has been incredibly fast, and I can only imagine it will pick up. So how have we been doing? I stole this slide from VITL so that I could compliment the providers in the room that have fought the tough fight to fight through what has been a difficult process of building EHRs in their practices. I know from talking with many of you and many of your compadres throughout the state how difficult it has been, how frustrating, how angering, and how often disjointed this process has seemed. I'm not going to sugarcoat it, it's not my style, but I'll tell you that we are not going to turn back, that we must push forward on technology. My restaurant company was wired in 1996. I mean, I'm just a little dumb restaurant company. That's where the world has gone. It's where we have to go, no matter how painful it is. It is where we are going. I want you all to understand that currently we do not have a majority of our payment systems based upon the patient experience. Patients would prefer a connected system of care that does not poke them unnecessarily, radiate them repeatedly, but I also believe that providers would love to have a basic patient information system that allowed them to have timely information in a time of crisis. Our hard-fought advances in technology will aid our efforts to care for patients in a more informed and coordinated way. This will lead to big data. I'm not sure how many of you saw the Wall Street Journal yesterday. On the back page of the first section was an ad by IBM. It was the size of the entire page, and in it, it told the story of big data and how quickly big data is growing. On CNBC this morning, there was a story on big data and how prominent of a role it plays in business today. Roughly $100 billion will be spent on big data this year in R&D in the business sector alone. IBM, a local friend, will spend $3 billion this year on research and development into big data. Why big data? Because big data plus analytics equals healthcare miracles. We may not be there yet. We may not be there yet as a country. We may not be there yet as a state. But this is where we are going. Everyone has to understand that. We will not turn back from this. We need VITL to work. So, John, you better heal up quick, brother.
I'm there.
And to all of you that work so hard to make all of this happen every day, who have fought through the frustrations, I take my hat off to you, and I just simply ask that you keep going. Thank you.
You good? Thank you, Al. And I am on the mend, working on it every day. That physical therapy, first thing in the morning after my coffee. I'd like to talk to you about 3 words that I hope will resonate today during the course of our remarks, during the course of the workshops you hear. Collaboration, urgency in our work, and ultimately providing value to healthcare providers around the state. Today, you will hear how we collaborate with the Department of Vermont Healthcare Access. You will hear how we are working on an integrated basis to support the Blueprint for Health's efforts, both from an EHR deployment, use, and also a particular focus on improving the quality of data. We focus our collaborative efforts not only with the Green Mountain Care Board, but as Al talked about, the State Innovation Model Grant, and we are excited, and I will continue to have my hand up looking for funding from that particular undertaking. So don't, just watch that. So look for me. Our VITL's activities also include working with the current statewide ACO, One Care Vermont, as well as their partner in analytics, the Northern New England Accountable Care Collaborative. I believe they have a exhibitor booth here today, so please learn about them. And as Al mentioned, we have 2 other ACOs emerging in the state. We very much at VITL look forward to working with them and supporting their efforts as well. While our primary focus is certainly on supporting healthcare providers, with our efforts, we also realize that Vermont patients do not just get their care in Vermont. And as a result of that, there is a focus today in a workshop, and if you get a chance to attend that, about how we are linking up with a sister health information exchange in Albany called HIXNY, the Health Information Exchange in New York, which receives substantial clinical data from Malone, Adirondack Medical Center, CVPH, Elizabethtown, the hospitals in upstate New York, so that care provided to Vermont patients in those hospitals will hopefully in 2014 be accessible to Vermont providers and the reverse for New York healthcare providers. And finally, our collaboration includes working with our Health Information Exchange vendor Medicity, from accelerating our interface development to deploying VITL Access, which we'll talk about a little bit later, the provider portal we hope to introduce the early part of 2014. So our focus in great measure is on collaboration. We're also all about urgency. Now, I don't expect you to read all the detail in this slide, but let me orient you to it. Along the top are the hospitals in Vermont, and we've added Dartmouth Hitchcock Medical Center. As many of you know, Dartmouth's patient population, about 40% come from Vermont, so the clinical data they generate is critically important to healthcare providers. Along the left-hand column are the interface types that are being built. Note the green stars that signify that the interface is live, and blue for being developed. This was the picture in the middle of January. This is the picture today. We have put an enormous amount of effort on accelerating this process through a variety of different approaches, and I would propose to you that we've made pretty substantial progress, and this will continue to be a focus of our efforts. Additionally, I think it's of note that in the last legislative session, this particular language was put into law. I'll let you read it. One of the major challenges for every health information exchange, every provider organization that tries to link disparate information technology systems together is the extent to which the issue of interoperability has not been solved in the United States. It takes a lot of time, effort, and complexity to marry these systems from a technical specification standpoint together, but that is the work that we're doing. This legislation puts special emphasis on this. This will be a collaborative process we undertake with you as healthcare providers around the state before we go to the Green Mountain Care Board. And I think it is probably, to my knowledge and talking to others, the only state that has this kind of legislation currently in place. So it signifies the importance of it. It will hopefully help us as we go forward with EHR deployment and interfacing IT systems. At the same time, we're working hard to bring Vermont's healthcare providers real value. Now, we certainly have been working with you on EHR deployment, building the interfaces, aggregating clinical data. Our interest is, if you look along the top of this slide, is what we're doing on interface development, where we're hoping to be as we get towards the end of this calendar year. You can never complete this completely. So our focus is to build as robust a group of clinical information that we feel will provide value, and then open that up for access and use following patient consent for healthcare providers in Vermont. We are currently piloting in 6 locations in 6 different levels of care settings, both the provider portal, VITL Access, and the new opt-in patient consent policy in Vermont. So along the bottom, as you can see, we have those pilots currently underway. We are learning from them. We're changing our approach. And our hope is that as we move into 2014, we will be opening up that provider portal for your use. I'd just like to show a short clip. Do be cognizant of the fact that this is real data, so you will see some aspects blurred out because it's PHI. So I just want to protected health information alert you to that. But we felt it would be kind of neat to be able to show this to you.
Hello, my name is Dr. Kate McIntosh, and I am the medical director of VITL as well as a practicing physician. And I want to tell you a little bit about a new product that VITL is starting to bring into offices called VITL Access. And you will have an individual login with a private password, and here is the search screen. So I am going to search for my patient. And you can only do this if you have consent from that patient to be able to look at their medical records. In this case, the consent had to come from his mother. So I searched for my patient, and here is my patient, and he has been seen at Porter Medical Center, at Fletcher Allen Healthcare, and at Northwestern Medical Center. I'm now going to look at his face sheet. Now, he is a complex patient. He's had many problems. So he has face sheets from 3 different places, and if you look over here, he has 5 pages of face sheets that are listed. So there's an enormous amount of information here that I might not otherwise get, and it gives me a picture of what his clinical course has been like. He has spent a lot of time in emergency rooms and hospitals, and it's very helpful for me to see it and be able to put it all together.
Another feature for us that we hope to introduce in the first of the year is a medication feed. This will provide medication history information on Vermont patients who have had pharmacies fill prescriptions anywhere in the United States. The hit rate in Vermont is very high, about 95%. It's lower in some other states, but it speaks to an additional capability that we will be rolling out at the same time after the first of the year along with VITL Access. So we hope this will support some of the medication reconciliation needs, and we're taking a look at how we may be able to tailor this more to provider-specific needs. At the same time, our future holds not just providing clinical data like radiology reports to providers, but also being able to share medical images, whether that be mammograms or MRIs. So we applied for a grant about a month ago. We're hoping to hear in January. That would accelerate our work in standing up an image sharing network in Vermont, but that will not stop our progress to that. The grant would help us move a little faster, but our intent is to be able to complement clinical data with the ability of providers with consent to access images regardless of where they were generated around the state of Vermont. And finally, we feel that if we're going to collaborate, if we're going to push urgently in our work, and if we're going to expect to have value, that we need to keep you informed. So in October, we will be introducing VITL's new website, just a couple of quick pages for you on how we're really hoping to make this far more user-friendly and be responsive to communicating to you on an ongoing basis.